Vidya, hi.
Hello.
All right, looks like we got most people here. We're letting the pictures come up. So why don't we go ahead and get started? Can everybody hear me?
Yep.
Okay,
Yep.
excellent. All right, well, for those that don't know me, my name is Derek Hershka. I'm one of the medical problem solving instructors for GOA. And the purpose of this module and this experience is to have you speak with a professional that knows a lot more than we do and have the opportunity to ask some questions about what they do every day and kind of their branch of medicine. So, with that, it's my privilege to introduce you all to Dr. Iyer, who is a interventional cardiologist and carotid artery specialist working in Manhattan, but with a very flavored past. So, having said that, what I'd like to do is have each of you introduce yourselves, where you go to school, and what grade you are in, and then we'll let Dr. Iyer take over. So, Vidya, why don't we start with you?
Hey, I'm Vidya. I go to Christchurch Episcopal School in Greenville, South Carolina, and I'm a senior.
Great. Simon, you're up.
I'm Simon. I go to Head Roy School in Oakland, California, and I am a senior.
Great. All right. Cami, I'm just going left to right on my screen here.
I'm Kami. I go to Polytechnic School in Pasadena, and I'm a sophomore.
Excellent. Megan.
I'm Megan. I'm a junior, and I go to the Pembroke Hill School in Kansas City.
Excellent. And Allie, you're near me, so why don't we put you up last? Go ahead.
Okay, I'm Allie, and I live in Connecticut, and I attend Kingswood Oxford School, and I'm a junior.
Excellent. The one thing I forgot to mention to everybody is I work at Brunswick School, and I live in Ridgefield, Connecticut, which is about an hour from where Allie is.
Ugh.
All right, Dr. Iyer, it's all yours.
Thanks very much, Derek, and good evening to all of you. It's been a real pleasure and a privilege to be part of this session. Thank you for submitting all of your questions as well. So let me begin by giving you a brief background of myself, who I am, and what do I do. So I completed medical school in Mumbai. I went through the University of Bombay after completing both high school and undergraduate, also in the city of Bombay. And medical school is a fairly long process, although that should not deter any of you who have aspirations of becoming a physician, either clinical practice or research. It takes time, but like any other profession, with each passing year, with each passing moment, you get more experienced, you develop more expertise, and tonight I hope to share some of those experiences with you. So after graduating from medical school, I joined a residency program. Medical school was about 4.5, 5 years, and then you do a year of internship. And then I elected to pursue the specialty of internal medicine. That's where I did my residency in a very large public hospital in Mumbai. We had more than, I would say, probably 1,200 beds, which is an extremely large hospital. And it gave me the opportunity to be very well trained, in the sense that I was exposed to a lot of disease conditions, and because there were so many patients from different strata of society, we had to also take into consideration, you can order 25 different tests, but we also have to keep in mind, can the patient afford it? Can the patient afford the test? Can the patient afford your medication? But be that as it may, it took me about 3 years to get through that phase, and at the end of that I became a specialist in internal medicine. And then I pursued my doctorate in cardiology. That was another 3 years. And at that point in time, I had 3 degrees to my credit. The basic undergraduate degree called MBBS, Bachelor of Medicine and Bachelor of Surgery, an MD in internal medicine, which we just talked about, the residency program, and my doctorate in cardiology, which was DM in cardiology. And at that point, almost 25, 27 years ago, I came to the United States and pursued training in a very specialized branch of cardiology called interventional cardiology. So interventional cardiology basically means that you are trained and have the ability to intervene so that you can make a therapeutic difference to a problem that the patient has. And very specifically, what I do, I am a specialist trained in performing a procedure called angioplasty. So you can imagine the blood vessels in the body like a tube, and there are arteries, there are veins. As we know, arteries supply oxygen-rich red blood to all of the organs. The veins drain the oxygen-poor blood from the organs back to the heart and get it oxygenated in the lungs. So my particular specialty is I treat blockages that form in the arteries supplying blood to the heart. These are called coronary arteries. And I also, over time, have trained myself, and in fact, myself and my group pioneered a technique of treating blockages in the carotid arteries, which are arteries in the neck that take blood to the brain. So that's called carotid intervention, and I'll show you some examples in a moment. So fundamentally what happens is just like plaque.
Can everybody hear that? Somebody's
Just
hollering.
like plaque can form on the inner lining of your teeth, beginning early in life, small yellowish streaks can form in the inner lining of these arteries. These yellow streaks are typically composed of things like fat, like cholesterol, and fatty acids, several unwanted things in the blood that slowly start to accumulate. So initially this is like a very small yellow streak, and it really does not interfere with anything that's going on inside the blood vessel. As we age and as we go through life, and especially if we have some features called risk factors, like if you're a diabetic, hypertension, you have high cholesterol, or if you have a bad family history, which means, let's say, first degree relatives, your parents or your brother, sister, uncle, if they have had problems of blockages in these arteries, especially at a young age, then all of these are what we call risk factors. And what these risk factors refer to is they increase your propensity for these blockages to get worse. So what started off as a small yellow streak on the inner lining of these arteries slowly begin to fatten up. And as it fattens up, it turns into a blockage in the sense that it starts to encroach on the space within the blood vessel. And so if the blood vessel were completely free, 100% of the space inside the blood vessel is available for the blood to flow through. If the blockage starts to form, then 20, 30, 40, 50% or even more of the space that is normally available for the blood to go through is now occupied by this blockage. And then if that blockage happens to be in the coronary artery supplying blood to the heart, we term that problem coronary artery disease. If it happens in the carotid artery taking blood to the brain, then we term it carotid artery disease. And if it happens to be in the artery supplying blood to your leg muscles, then it goes by the term PAD or peripheral arterial disease. And depending upon which part of the circulation is affected, that will then influence the kind of symptoms that the patient presents with. So for instance, a patient with coronary artery disease can come to me and say, "Doctor, the other day I was walking down Manhattan and after I walked 2 blocks, I suddenly started experiencing this little chest discomfort. It was as if somebody was squeezing something inside my chest. I thought maybe I pulled a muscle, so I continued to walk. Then that pain went down my left arm, started having a little sweating, a little tightening in the throat. When I hear these symptoms, it's almost a telephonic diagnosis that this, unless proved otherwise, is a problem caused by blockage in the coronary arteries, and what the patient is describing is what we call angina. So that's classic presentation of coronary artery disease. If the patient has got, let's say, carotid artery disease, it could be, and any of these blockages can be completely asymptomatic. The patient may not even know that these blockages are there. But what I'm describing to you are symptoms that are related to these blockages. So if, for instance, a patient has got a blockage in the carotid artery, the symptomatic presentation can be something like this. She may say, "Doctor, the other day I was watching my favorite television show, and all of a sudden I felt as if a curtain was coming down my right eye. And I thought, my God, let me rub my eye and maybe it'll go away." And it went away after about a minute or so, and I didn't think anything about it. And 2 days later, it happened again. So this is what it goes by a very fancy name called amaurosis fugax. You don't need to remember the name. But what the patient is telling me is that it again, a very classic symptom of the retina in the eye getting a problem with blood supply. And we immediately think in terms of carotid artery. Or the patient may be brought by his son or daughter and say, "I was talking to my dad the other day, my dad could not speak." It's a classic symptom because the speech center in most of us is located on the left side of your brain. So if a patient comes to me and says, "I had this speech disturbance for about 5 minutes and it became okay," I immediately think, is there something wrong in the left carotid artery? There are other reasons why, but I'm just giving you. And finally, for peripheral arterial disease, how does that manifest? Well, he'll say, I have been an active person, I've run, I've walked, but for the last 6 months, every time I walk 3 blocks on level ground, I get this cramping in my calf muscle. I stop for a few minutes and the cramp goes away. This is what we call claudication. Claudication is from the Greek word which means to limp. So what it also is called window shopper's disease, because what the patients learn to do is they walk for 2 blocks, pain, they stop. They don't want others to notice why are you stopping, so they start looking around in the windows in the street, in the shops around. The pain goes away and they walk again. So 3 different circulations, same idea, blockage in the arteries, affecting the circulation to the organ, and the manifestations are different. So when the patients come to me, that then triggers a series of tests that I do, and once I diagnose that they have this problem, if I can treat this blockage, let's say I put a balloon, and I'll show you in a moment, a balloon inside the artery to squish that blockage, literally like footsteps on freshly fallen snow, that is what is called as angioplasty. You're repairing the blood vessel with the blockage, and this time I'm using a balloon to squeeze out that blockage and increase the space for the blood to go back. So I know I've given you a lot of information. I'm going to stop here for a second, and then if any of you have a question or questions, I'll take that. I've put together a small PowerPoint presentation. Let's hope it plays on your screen to illustrate some of the concepts that we just spoke about. Well, let's see if they have any questions.
Okay. I'm Anjali, by the way. This is my dad. And Mr. Huska.
Derek, was that okay?
That was excellent.
Okay.
That was really, really good.
Okay.
Thank you.
I'm share my screen with.
So give us a moment. I'll show you some of the things that we just talked about, and hopefully that will trigger some more questions and make this more interactive.
Do you want me to go straight into slideshow?
Slideshow, please.
Okay.
Tell us when you can see the screen. It should say extracranial carotid artery disease.
I can see it.
Okay.
I can see it.
Yep, we're up.
Okay. So what you're seeing here, and you can see my arrow on the screen.
Yeah,
This,
do you guys see the mouse?
do you see the mouse moving here?
Now we do, yeah. Yep.
Yeah.
So what I'm showing you here is the spine in the neck, and that's what's called the cervical spine. So what you're seeing, this entire area is a patient's neck, and these dark lines that you see are the two carotid arteries in the neck. So there's a right carotid artery, and there's a left carotid artery, and about halfway up the neck, the carotid artery splits into two. You can see this guy here has got all these branches. This is called the external carotid artery, and this one here with no branches is the internal carotid artery. Why internal and external? Because the internal carotid artery goes through the skull and supplies the brain. The brain sits here, right here. And this is the external carotid artery, which supplies everything outside the skull, the skin, the face, the jaw. Now what I want you to see is this part right here. Can you see that where I'm pointing the arrow?
Yes.
So this is the blockage that we talked about, caused by typically cholesterol and other some unwanted substances. So ordinarily, the internal carotid artery, if there was no blockage, should be uniform. There should be nothing here. It should be one straight, two parallel lines. Because there is a block in C, there's only a very small sliver of space that is available for the blood to go through. So if I look at, and what you're seeing in front of you is what is called an angiogram. And because the artery involved is a carotid artery, this angiogram is called a carotid angiogram. If I do this in the heart, it would be called a coronary angiogram. So this blockage was responsible, let's say, for either a visual symptom or the speech disturbance, or the patient could also present with sudden weakness of the left arm and the left leg. Why do I say left arm and left leg? Because what we're looking at is the right carotid artery. The right carotid artery supplies the right half of the brain, and the right half of the brain controls the left half of your body. So it's reversed. And you don't need to know the mechanism, but remember that. That's important to remember. That's always in that fashion. So this is the blockage. This is the problem. So what can I do? So let's take a look at the next slide. Actually, I want to show them.
Which one do you want?
Okay. Can you see this one?
Mm-hmm.
Yes.
So this is what a device that we use during the angioplasty procedure. This is what we call as a filter. You can see that this has got a fabric with some holes in here, and I'll show you why. So these holes, this whole device, this filter, is placed above the blockage, so that when I open the blockage with my balloon, I will let loose small pieces of particulate debris. If I don't put this filter, all of that particulate debris can go up into the brain, clog up the arteries, and cause a complication. So what this filter does, and I'll show you how this filter is placed, is it'll allow the blood along with the debris to enter through these big holes. The debris is caught inside the filter, and through these very small holes, the blood continues to go up to the brain while I'm working on the blockage. So this way I do not interrupt the blood supply to the brain, but I make sure that as far as possible, the debris that is let loose when I put a balloon into that blockage does not reach the brain, because that can cause complications. So this is called a filter or a brain protection device for obvious reasons. So here is how this works. So take a look. So here is a graphic or a cartoon of the carotid artery. You see all of this yellow stuff. This is all the blockage. I've put a balloon across the blockage and I've inflated the balloon. Now you see all these small particulate debris. All of this gets released because I've stretched that blockage. And that debris then goes through those pores of the filter. It is trapped by the filter, but you also want the blood to go up north to the brain. And that keeps going and goes through the filter. At the completion of the procedure, we can collapse the filter like an umbrella and bring it out. So this is a temporary thing that we place only during the procedure. So this is one thing that this is one device that I use during the angioplasty of a carotid artery. The other device is right here. You see this balloon? That's why it's called a balloon angioplasty. When I inflate the balloon, I literally squish the blockage and push it to the side of the artery. And then I will use something called a stent. See this thing here? This is a metallic mesh.
Does everyone see the self-expanding stents?
Mm-hmm.
Yes.
So what a stent is, it's like a metallic scaffold. So when I use a balloon inside an artery, the artery can behave like a rubber band. When I inflate the balloon, the artery inflates with the balloon, and when I let the balloon down, the artery can recoil. So to prevent that from happening, I put in this metallic mesh, which is placed inside the artery. It actually typically acts like a scaffold and holds that artery open. This is what is called a stent. It's a very cool thing because this metal is made of an alloy called nitinol. Nitinol is an alloy of nickel and titanium. And what's so cool about it is when it meets 37 degrees centigrade, it automatically springs to the diameter that it is taught. So for instance, why 37? Because that's the temperature of blood. So when I put it inside the body and I pull this restraining cord back, it will expand and it will jump up to, if it's 6 millimeters or 7 millimeters in diameter, it will get up to that diameter. So anyway, it's a very cool technology. So we use a balloon, we use a stent, and we use a filter. And when we do all of those things, in about 30 minutes, we can take that kind of blockage at baseline and you can create something like this. So you can now see how that blockage has been resolved. If you look carefully, you'll see something here stretching from there to here, and you see the little net-like appearance. This is the stent. The filter was here. I've already taken the filter out. And now you can see we have expanded the space available for the blood to go through. We have fixed the blockage. If the patient comes out without a complication, we would term this a successful carotid angioplasty procedure. So just to give you a sense as to what, because some of you ask me, what do you do every day? Well, I see patients with coronary disease, peripheral vascular disease, carotid disease, and this is something. I'll show you one more picture. Here is another example. So here's another right ICA stenosis, simply means right internal carotid artery blockage. That's what it looked like before we put the stent in, and that's where. Now, stenting is not the only way. You can actually do surgery and I do not do surgery. Surgery is done either by a vascular surgeon or a neurosurgeon, where they will make an incision in the neck, expose the carotid artery, and actually take the blockage out. So anyway, so just to give you a flavor of what my specialty involves, what I do on a daily basis, and what angioplasty is all about. So let's go off these slides and let's open it up to some questions, and let me see if there are, while you are thinking of your questions, I'm just going to go through some of the questions that you guys have sent me. Derek, maybe you want to kick off some questions so while they're still thinking about it. Yeah.
Well, I want to make sure everybody realizes this is your chance to ask Dr. Iyer any questions that he hasn't answered. I think the lecture's been terrific so far. I'm utterly like thrown back. I want to go back to medical school. That's what I really want to do right now. The question I had as I was watching the stent work, because these are surgeries that I've seen and observed when I was in training, the stent and the alloys, how recent are the temperature sensitive alloys in terms of research technology? Is that something that's come out in the last couple of years, or has that been around for a while? Or if it has been around for a while, what's on the horizon?
So the stenting was introduced. The first stents that came out in the late 80s, and typically they are the initial ones were all stainless steel. There is surgical grade stainless steel. We call that 316. When we say surgical grade, what it means is it should not rust or it should not degrade. So that's why it's a very special kind of stainless steel. The alloy that I showed you, nitinol, that was introduced into medical practice in about 1995, 1996. So it's been around for close to 20 years. These are permanent implants because metal is not going anywhere. Once you put it into the wall, once you put it inside the artery goes through a healing process. The body's own tissues will cover the surface of the stent, and the stent in time gets incorporated into the wall of the blood vessel, but it is a permanent implant. So what we do know, for instance, these stents also put in the coronary arteries in the heart. But what happens in the heart when you put it inside the coronary arteries, in about a third of the time, these stents will re-narrow. And the reason why it re-narrows is because there's a particular tissue generated by the division of smooth muscle cells. So when you injure the coronary artery by stretching it with a balloon and putting your stent in, the artery will respond with the healing process. And during the healing, there is the proliferation or the division of smooth muscles, which then encroach as a tissue and go through the interstices of the stent and re-occlude the stent or re-narrow the stent. This is what we call restenosis. In order to reduce that, what we have done is about 10, 12 years ago, we introduced something called drug-coated or drug-eluting stents. So what a drug-coated stent is that the stent that I showed you is a plain vanilla bare metal stent. You can coat the stent with a little polymer, and on the polymer you can combine it with the drug. The drug has a very special property, and the property is that it can suppress the smooth muscle cell proliferation. And when it suppresses the smooth muscle cell proliferation, it will reduce the chance that that stent will re-narrow. This is a huge advance that we made because, think about it, we knew that we needed to reduce this blockage, but we had no idea what kind of drug we needed to use, what should be the dosage, how do you combine a drug to a polymer in a metal that is so tiny, but it's all been done. So today, that's, if you hear, oh, I got a stent, you got to ask, did you get a drug-coated stent? Because once you put a drug-coated stent in, the risk of the stent re-narrowing is less than 10%. Without the drug, it could be 35%. Anjali, just bring up my PowerPoint slides, please, one more time. I'll show you an example. I put one of them in case that question came up. So just next one. You go up. No. Come down.
Right here.
No. Okay, come down. Keep going. Keep going. Keep going. Yeah, this one. This pink one. Pink one. Okay.
Sharing the screen.
All right. Give us a second, and I'll show you the concept that we just spoke about. When all of you can see the screen, let me know.
I can see it.
Okay. So look in the top left corner where it says bare metal stent. So what this means is we have put a stent. You see all these cut surfaces? This is because what you're seeing here is a cross section of a bare metal stent, no drug, no polymer, nothing, inside the coronary artery of a pig. So this is a porcine coronary artery that has received a bare metal stent. 28 days later, when you do a cross-section of that coronary artery and you stain that tissue with a stain called hematoxylin eosin, that's what's called H&E staining. You see all this stuff here? These are the struts of the stent. This is the lumen of the blood vessel, but you see this pink tissue. This pink tissue is all come about here because of proliferation or division of smooth muscle cells. And this smooth muscle cell is now growing through the interstices of the stent and encroaching on the space inside the blood vessel, and that's why that stented patient has now got a re-narrowing, what we call restenosis. Take a look at that panel immediately below. This is what happens when you put a drug-coated stent. So this stent has got that polymer and the drug. The drug acts very locally. It's not like swallowing a pill. It's only on the interstices and on the metallic struts of the stent. And now you can see the difference between the thickness of the smooth muscle cell here versus here. Because it has suppressed that smooth muscle, there's a larger hole or a larger lumen dimension that is available for the blood to go through. And this is what we were talking about a few minutes earlier. This is the benefit of a drug-coated stent. So Derek, you were asking me what other things are coming down the pipe. The latest technology is that these are all metals, right? They are permanent implants. Now we have stents that are made of polymers that over time, 12, 18, 24 months, they can biodegrade and completely go away. So you do an angioplasty, put in a biodegradable stent, which provides the scaffolding that you need while the artery is healing. You combine such a drug with the biodegradable stent so that it delivers the drug for the first 1, 2, 3 months. The healing is complete. You no longer need the stent biodegrades, and it completes the course. So that's where we have moved it. So from plain balloons in the 80s and 90s to bare metal stents through the 90s, through drug-coated metallic stents through the first part of this new of the 20 till 2010, 2014, and looking forward, you can see improvements in biomaterials and making things safer and more effective. Let's go back.
That's amazing to me. I love watching how the research gets done. This is your chance, you guys, to ask Dr. Iyer some questions. We don't want to go too late into the evening here. I think he's done an amazing job of answering questions that were provided to him when you guys filled out your Google Doc and signed up. But I'd like to open it up for you guys to ask him questions directly. And go ahead, Simon, you're up.
Can you talk a little bit about the complications? I feel like couldn't the balloon, when the vessel is so weak, burst the entire vessel?
Yes, it can. So what you're asking is, what kind of complications can we potentially anticipate when you put a balloon inside somebody's artery? Yeah. So what you just described is what is a dreaded complication of what we call arterial perforation or arterial rupture. And the way there are two instances where you can think about it, where you can encounter it. One is if your balloon is oversized. So for instance, if your arterial size is, let's say, 2.5 millimeters, and for whatever reason you misjudge the size and you put a 3.5 millimeter balloon, that mismatch, something has to give, and it's not going to be the balloon typically, but it is going to be the artery, and you can perforate the artery. So that's one instance where you can encounter this. The other instance where you can encounter this is in cases where the blockage, which I described as yellowish streaks and fat, etc., it can be soft and putty like clay. Those are very easily moldable. But not infrequently, you get calcium deposits in in these blockages, so that now instead of something that is soft and putty, it becomes really hard like concrete. And that is very, very difficult to compress with a balloon. But if you continue to do that, and let's say you dial up the pressure in the balloon, because you can use, very low pressures. If it is soft, it'll easily push away. But if it is very hard, then you keep on cranking up the pressure in the balloon, and typically what happens is only the entire circumference of the blood vessel is not covered with blockage. About, let's say, it's like a crescent. So that part contains that calcified blockage, and that does not give. But the opposite wall, which is relatively normal, is also encountering the force of the circumferential balloon, and that gives way. So that's why we have to be careful when we see these kinds, and when you realize that the blockage is not giving way with your balloon, then we sometimes use a high-speed drill. We drill away the calcium, take away whatever is restricting our expansion. So now you're moving away from simple balloon angioplasty. That's called rotational atherectomy. So there are other devices that we use. But yes, you asked a good question. It's one of the dreaded complications because it can be potentially life-threatening.
Anybody else? Go ahead.
I was wondering, since I know these sort of procedures are minimally invasive, after a patient has one of these procedures, how long would they have to stay hospitalized?
So, yes, these are all minimally invasive or clearly very, very different from surgical incisions. So, you could, in theory, discharge these patients the same day. So I can do a procedure in the morning and I can send these patients by evening, they can go home. But most often, we like to observe these patients overnight in the hospital. So almost 95% of these procedures are done with one night stay in the hospital. Although same-day discharges, outpatient procedures are all possible, it's an individual preference of the physician. Most of us would like to keep these patients for one night.
Thank you.
You're welcome.
Now I want to make sure that we respect the time, so we have time for maybe one or two more questions. Why don't you go ahead, Allie?
I was wondering if there was more of a risk in in a certain artery when doing this procedure.
The risk is related.
Is it the same for all three?
No. So the risk is related to two things. One is, what is the end organ that artery that you're working on, what does it supply? So for instance, obviously, between the brain and the heart and the leg, even small disturbances of circulation in the brain can end up as a stroke. The heart, yes, you could have problems, but the redundancy and the spare capacity, if you will, can overcome smaller problems in the heart and the leg more so. So that's one thing. The second thing is, in case like what was asked to me earlier, I think Derek, who asked me the question, was it about the rupture?
That was Simon.
Simon asked me about the rupture. It's a question of how quickly can you get to it. So for instance, if there is a problem inside an artery that is located in the chest and the artery ruptures, what do we do? What we do, Simon, is we can go back in with a stent that has got a fabric around it. It's called a covered stent. So now if you put it inside and you expand that stent with the fabric seals off the hole where the artery is perforated. But it doesn't work all the time. Sometimes, despite all of you may not be able to deliver the stent. So then in this case, you have no choice but to crack open the patient's chest. So that's what I mean. It takes the approach to that becomes more difficult, as opposed to, let's say, it's an artery superficially in the leg, you can get to it very quickly. So those are things that influence whether or not how we present the risk versus benefit to the patient when I discuss these procedures of baseline. So I know we have maybe a couple of more minutes. I'm going to take one question that you sent me, which I did not cover, and that was, how do I handle a Jehovah's Witness? That's a very interesting question. So this is a problem, right? I mean, as you all know, Jehovah's Witness will basically refuse to take any blood or blood products. And in my experience over the years, there are gradations of refusal. Some people will say, no, absolutely no. Under no circumstances will I accept any blood products. Some may say, well, if my life is really in danger, etc., you can go about it. But it is a big problem because you literally are going into this procedure with one hand tied behind your back. Because think about it, you are essentially working in a space, in a blood vessel, that for all the reasons that we talked about, is inherently prone to a problem of bleeding. And if I do not have the ability to replace that blood product, then it becomes a problem because it potentially increases the risk of the procedure for the patient. So there is no easy answer to this question. So things that we sometimes do are bank the patient's own blood. Sometimes they don't even accept their own blood. Some people say, well, if it's my own, I may be able to. But that is one avenue that we offer. The second thing is we say, well, if there's an alternative to the procedure that I am thinking of, and if the bleeding risk of an alternative approach is less, we would recommend the alternative approach. And occasionally we have walked away and said, if you're not going to accept blood products, we think that the risk is prohibitive and we will not be able to do this. In New York City, for instance, there are some surgeons who are specifically devoted their careers, for instance, to dealing with Jehovah's Witnesses for big surgeries. So they have a particular protocol that they follow, not that they are better than somebody else, but you become very disciplined in the amount of blood loss, etc. But again, it's a very, very difficult subset to deal with, and unfortunately, there's not one answer that I can give that will be applicable to all patients across the board.
Any last minute short questions, guys, before we close for the evening? As we all sit here uncomfortably staring at each other. Anything? All right. Okay.
Well, I've given you a lot of information. I just wanted to basically shock the system a little bit. So,
I think you succeeded.
yeah, I hope I have. Right. But look, at the end of the day, it's fun. What I do is basically a very sophisticated plumbing job, right? I mean, it's only that it happens to be inside your body, so we respect it a little bit more, but essentially it's a plumbing. Something is clogged and we need to unclog it. We use sophisticated tools like I showed you of filters, balloons, stents, rotobladers, atherectomy devices. But at the end of the day, the fanciness of these procedures should not tempt you to go into medicine. There should be a true passion. And let me tell you, it doesn't happen on day one. Like if you ask me, why did I go into medicine? It was not that I had any special love for the subject. It is something that develops over time. The dedication, the number of hours we put in, I don't think twice. And it's not because it's something I am very special. Over time in the profession, as you deal with patients and families and you realize that you have that unique gift to bring comfort to a patient's life at the moment of suffering, to comfort a family, those are all extraordinarily powerful gifts that we don't underestimate. So again, some of you have asked me, why go into medicine? What does it take? What should we know? The simple thing is keep an open mind. You should have a very good grounding in the sciences, including some math, especially if you go to research. Let me tell you, statistics will keep on popping up. You'll say, my God, I thought I went into medicine to get away from this, but unfortunately keep on popping up. So a wide good baseline grounding, love for the subject that keeps on developing with time, and of course a good score. That's what's going to get you in.
Well, I appreciate your time. Anjali and Dr. I'm going to ask you to hang on to Skype for just a second. I'm going to basically kick everybody else out of the call, and we'll wrap up that way. So for the students, I want to say thanks for coming in. I hope you enjoyed it as much as I did. I don't know if you did, but I loved it because I understood what he was talking about. Go back to your own groups, go back to your own instructors, and take back what you learned. Keep in mind that this whole entire session has been recorded and will be put up on a YouTube channel. And once that's available and ready, which means for me tomorrow morning, I'll let you know. Okay? So having said that, thanks everybody for being here. And Anjali and Dr. Iyer, if you guys could hang on for 1 second, I'll be back in a minute.
Thank you very much, and good luck to everyone.
Thank you so much.
Thank you.